So I think we will get going while the last few people get their lunches here. It's my pleasure to introduce Dr. Michael McDonald, who is an assistant professor here at the University of Washington, is actually primarily located here at Harborview. So Michael came from Washington State University and then did his fellowship and postdoc work here in our department, working with technologies that help the severely mentally ill. He specifically now has 2 R01s, I am told, to look at how behavioral technologies can be used to help those with addiction and comorbid severe mental illness. So we welcome Dr. McDonald.
Thank you, and thank you everyone for coming. So I'm going to talk, when we talk about the term behavioral technologies, these guys are asking me what that means, and what I mean by behavioral technology is not that, we're going to see, I'm interested in technology, like things like mobile apps and things like that, but as you'll see in our talk, what I'm talking about behavioral technologies, I'm talking about sort of psychosocial interventions that can be given without sort of the need for talk therapy, or even sort of the need for a trained clinician. So I'll talk a little bit more about that as we go. So the talk I'm primarily going to focus on our research program that was started by Rick Reese and here in our department, and I've kind of collaborated and sort of taken the lead on, which is really focused on using contingency management, or motivational incentives is what a lot of people call them, to treat drug and alcohol dependence in severely mentally ill adults. And then our work is now progressing into working with other populations that are affected by addiction health disparities. So hopefully, if we have time, I'll talk a little bit about our work with Native American and Alaskan Indian populations. Excuse me. So contingency management. How many of you have heard of contingency management before? Well, I'm glad you have. And how many of you have heard of motivational incentives? How many of you get paid to come to work? Okay. So the idea of motivational incentives or contingency management, incentives, I have a 4-year-old, so he has like 10 different sticker charts. We've got a whole wall of sticker charts and things he's earned. And so this idea, I'm trained as a child psychologist too, and so this idea of like rewarding people for doing something you want them to do is seems sort of obvious to me. And when I heard about this as a treatment for drug addiction, so contingency management is the sort of term we use for this, using rewards to get people to stop using drugs. That's basically the idea of contingency management. And up here you see a few things, like you see a picture of Nancy Petrie from a while ago, I think, and she's got her famous fishbowl. We use an IKEA yard waste disposal bin instead of a fishbowl in our study, but that's just a small thing. So that we'll talk some more about prize draws, or the fishbowl technique, which is one kind of contingency management. And here's the book that was written by Steve Higgins and Ken Silverman on contingency management and its applications in substance abuse. So the idea is, again, contingency management is very simple. The idea is we just give people a reward for not using drugs, or in some studies, for using fewer drugs. So this was just something that someone who is sort of part of our group but more recently joined our group sent me an email with a link to a New York Times article that just was out that actually talked about this study, not this study particular, but a study like this one. So contingency management in the drug abuse world comes from this idea that people who use drugs, do use drugs for good reasons. People who use drugs are not out of their mind. They're not, they make rational choices. And so this study, which has been replicated for almost every drug and alcohol in humans and in other mammals, has shown that, and this is for people, what they basically did in this study was they brought in people who were cocaine dependent into an inpatient hospital, like our inpatient hospital across the street, not there though, and they basically gave them 5 lines of cocaine. So they said, here's 5 lines of cocaine, use them. They wanted to make sure they weren't just some random college students, and they wanted to make sure they actually were cocaine users. So they gave them 5 lines of cocaine one day, and then they said, sleep that off, or run around for a while. And then they had them come back, and the next day, and they said, okay, you get to choose a line of cocaine, or you can choose 5 cents. So, right, most people are going to choose that line of cocaine, right? Not 5 cents. What are you going to do with 5 cents? This was a long time ago, so 5 cents might be 10 cents now. Then they said, well, we'll offer you $1. And, wow, about 6 out of 10 people still chose the cocaine. But when they offered them just $2, 8 out of 10 people chose the $2 instead of a line of cocaine. So this is a sort of famous analog study that's been replicated in a number of different drugs, and basically, this was sort of this kind of study was highlighted again in the New York Times recently, and it really suggests that people who have drug addiction or drug dependence or whatever we're calling it now, or substance use disorder, this drug's reinforcing to them. But if you could offer them some other kind of a reinforcer, they might choose that instead. So principles of contingency management for drug abuse. The first thing is that you have to frequently monitor your target behavior. So in contingency management, we have these, from other drugs besides alcohol, we have these inexpensive urine cups, which most of you have probably seen, or dipsticks you can dip into your urine. Parents like these for their teenagers even. And it can detect, for the most part, about 2 to 3 days whether or not you've used at a pretty significant clinical level. So we've got these cocaine tests that can tell for 2 to 3, maybe 4 days whether or not a person's used cocaine, and your results are instant almost, right? They're like within less than 5 minutes, and so that drug test, if you give that on a Tuesday, Thursday, or Monday, Wednesday, Friday, you can pretty much monitor it, make sure that a person hasn't used. You're pretty confident if you do that they haven't used. So you frequently have to monitor that target behavior, and you have to provide a reinforcer, right? These are sort of back to your Psych 101 class. You have to provide that reward. If you want to increase a behavior, you provide the reward right after the behavior occurs. So I'll show you actually a video of our STAR research coordinator doing the whole procedure, contingency management intervention with someone, but you'll see how it kind of works. And then the other thing, in contingency management, we don't punish people. So most people, when they come in and give a urine sample, they get punished because they're going to go to jail if it's positive, right? Or they're going to lose their job. So when we do urine testing, we might withhold a reward. Like if you come in and you give a urine test, we're not going to give you prizes. You're not going to get a reward, a voucher or whatever your reward is, but we're not going to punish you. We're not going to say, take something away from you. So that's another important thing about contingency management. So now I'm going to show a video, because the best way to show how you do this is a video. And our star is right down here, Frank Angelo. Yeah, there he is. And this is the video of Frank doing the whole contingency management procedure except for the urine collection. We didn't think we wanted to show that on video, with some of our former participants who have really succeeded in the study. So go ahead and get started. So what you're going to see what we use is the fishbowl, or the variable magnitude of reinforcement procedure, which is there's two kinds of general contingency management that is kind of well researched and are out there for clinical applications. And one is a voucher, where you basically come in, you give a urine test, and then every time you kind of save up your negative urine tests, your rewards every week. You might get $2 every week, and you save it up and you get it written on this little voucher. And then when you got like $20 and you wanted that new CD by Beyonce, you can trade that in for that new CD by Beyonce. Frank will go to the store and he'll buy it. The other approach is we actually have these, which is that you earn prize draws. You earn, and we'll talk some more about this, but you earn the ability to reach into this bucket, and in that bucket, half the tokens say "good job." Keep up the good work. The other half have a prize value associated with it, and the prize value is small, large, and jumbo. So small is about $1 prize, large is about a $20 prize, and jumbo is a $100 prize, $80 to $100. And you have a different chance. So you have a pretty high chance of winning one of those small prizes, a 40% chance or so. You have about a 7 or 8% chance of getting a $20 prize, which is mostly gift cards, and you have a 1 out of 500 chance of getting that jumbo prize, which is like a portable DVD player, $80 worth of gift cards. It's a pretty big deal. And so the way it works is, in our procedure, is you start out in the last study we did targeted stimulants, and you'll see what Frank does here. You reach in that bucket. You get one time you reach in that bucket for if you're negative from using the target drug, which in our case in this last study was stimulants. You get an additional one if you are negative from all other drugs, because we want to help you. If you want to quit other drugs, we want to help do that too. And then the longer you're abstinent, the important thing is the longer you're abstinent, the more draws you get. So in the first week, you get 2 draws if you're abstinent from all drugs, the first Monday, Wednesday, and Friday. So you're probably going to get a couple prizes. Maybe you'll get one of those $20 prizes. But if you're abstinent the whole study, by the end, you're going to get 13 draws in that bucket every Monday, Wednesday, Friday. So, we have people walking out with little bags, right? They're walking out with bags of stuff. And sometimes getting those $100 prizes, $80 to $100 prizes. So that's the kind of background of this, and Frank kind of really demonstrates how it's done. And again, you'll see this video is only 2 minutes long. That's how long the visit takes, besides actually getting the urine collection, which is probably another minute. Can you guys hear that? fine as it goes.
So we are going to check this here. How's your day been? Pretty good. Good, good. So now we're looking to see that you are clean for cocaine, amphetamines, methamphetamines, THC, and heroin. Since you've been in the study for 4 weeks, I'm going to get 5 drops. Sound good? Excellent. Okay, first draw. Good job. Nice. Back in there. Small. Great. Good job. Small. Hey, all righty. That's too small and large. So stand up.
See how little space you need to do this intervention? Frank's not laughing.
Oh, wow. What a decision. Oh, no. Yeah, the lips.
You get another small too.
One more small. Is that a whole cup full of these?
I'll do just one each.
Oh, well. I'll take
Great.
those this time of year. Okay.
And a large.
And a large. Is that good?
Yep, that's like this go.
All right.
That's not how Dr. Phil does it.
I know. Well, last time I gave this talk, I had some much more inappropriate videos that came up next, but I changed my kind of YouTube viewing history. I didn't want to embarrass myself again. So that's contingency. I mean, that's how long. That's literally how long the visit takes, with a few more minutes for the data collection and some of the research measures we get. And you can see how positive it is. Like, these are folks who have done really well. This is probably like 6 months to a year after they finished the contingency management intervention, that have come back and volunteered to be in these videos with us. But so they're sort of unique in that all these folks had maintained sobriety or abstinence for that long. But this is really positive. Like, you really get this positive vibe throughout the whole clinic, and you really see a change in the kind of clinic. And because the way that this would have went out, if one of these folks, if this person would have come in and tested positive, Frank would have been like, "Hey, see you in 2 days. We'll try again." And so that's where we try to really focus on the positive. So that time that person wouldn't have gotten a reward because they'd used, but we would say, come on back on Wednesday. Because again, we're seeing people Monday, Wednesday, Friday. It's not like a court situation or another typical clinical situation where you see them once a month. We'd say, you know what, you slipped up. That's what it is, and we'll see you on Wednesday. So people get motivated because they can come back in a couple days and try again and get prizes. So that's that. Any questions about that? So that's one kind of contingency management, and that's the contingency management intervention we tend to use. So why talk about it? So again, studies like that cocaine study I just showed you, the kind of show that really drug abusers will, if people who use drugs will make a choice to choose other reinforcers. Now the thing, especially in a lot of folks' lives, especially in people who have, like, let's take for instance our target population, or people who are using drugs who are seriously mentally ill, there's not a lot of other reinforcers in their lives for a lot of people. They don't have a lot else reinforcing for them. And so this really offers, besides drugs. And so this kind of offers an alternate reinforcer to them for a period of time that really gets them engaged in abstinence, really gets them hooked onto the idea of abstinence. And then hopefully in that abstinence they can develop their own natural reinforcers. So again, why talk about it? We see these data that seem to support it in analog studies and artificial settings. And then in the meta-analyses, especially for drug abuse, there seems to be about, that contingency management relative to all psychosocial treatments seems to be the most effective at getting people to stop using. And that duration seems to last for up to a year in some studies. And it's proven effective for almost every kind of substance use disorder, and we'll talk a little bit about alcohol, sort of the exception to that. So this is the study that Rick Reese was the PI on. It was a strong partnership with the Community Psychiatric Clinic here in Seattle, and then also with the county Mental Health and Substance Abuse Division, where Deborah Shrebnick works. And then also all of our work is, you'll see across all of our studies, is a very strong partnership with Washington State University. And John Roll is, Dr. Roll is one of the originators of contingency management interventions. So the first group is we're targeting psychostimulant use, and particularly crack cocaine use in seriously mentally ill adults who are receiving treatment in a community mental health center. So a lot of you will know this already, but co-occurring disorders are a very common problem in this population in seriously mentally ill adults. So again, we're sort of talking about the federal definition of serious mental illness or severe mental illness, which is schizophrenia, bipolar disorder, and really severe major depression. So these are folks who come to our community mental health center here, who go to receive most of their psychiatric care in community mental health centers. So these are people with chronic mental illness. So about 20 to 50% of them have recently used illicit drugs within the last month or so. And 50% have a diagnosable substance use disorder at some time in their life. So this is a common problem. And as any of you have worked on community mental health or in the inpatient unit here or in the PES know, right, that people with substance use disorders with serious mental illness just have worse outcomes. They do. And they cost more to treat. They utilize more acute care. They're more likely to be homeless. They have increased cognitive impairment. Rick has even shown, and Deb Shrebnick and other folks here have shown that they have a reduced ability to even manage their basic finances. So they get into a lot of trouble in that area, and they have poor treatment compliance, et cetera, et cetera. So this is an important thing to treat, both these conditions. And still it remains the case, although I think it's changing a lot, that substance use and mental health are seen as two separate conditions. And these data on just co-occurring disorders in general show that only about 12% of people report getting treatment for both co-occurring disorders, so substance abuse and their mental health concerns. I think these data are a little out of date, so I think they're changing, but more recently updated data are not that much, not that overwhelmingly different. So further, more of a concern is that few of the co-occurring disorder treatments that are evidence-based have shown an effect on both, in studies, have shown an effect on both substance use and mental health symptoms. So there's very few of these treatments, and the treatments that are out there that that are evidence-based for co-occurring disorders are pretty intensive. They require you to be trained to fly off someplace, or have someone come in, pay someone to train you. You have to be adherent to the treatment to see the same effect, and they're relatively intense. And they're relatively intense in the amount of visits you might have in a week, or the amount of visits you might have in a month, and they require this kind of long, professionals to be able to deliver them. They require trained therapists to be able to deliver them. So, some interventions have shown reductions in seriously mentally ill adults with substance use disorders in group counts, have shown reductions in drug use. Others have shown, things like the legal system and therapeutic courts have shown a reduction in things like psychiatric symptoms, but very few of these treatments have consistently shown a reduction in both. So that leads us to the study that we've just finished I guess it's not just, it's about 2 years ago now. It feels like it was just a few days ago. Which is to look at whether or not this contingency management treatment, this fairly simple, low-cost treatment, if we just added it on to treatment as usual in a community mental health setting to treat substance abuse, could we find reductions in their drug use, specifically stimulant use? So again, this is a 3-month intervention. And could we also see reductions in other drugs and alcohol use, and reductions in psychiatric symptoms, and our hope, which is based on some research previously, was that we'd see reductions in things like hospitalizations, incarceration, substance abuse treatment utilization, inpatient substance abuse treatment utilization. So we're hoping to see that this simple intervention could maybe impact both substance abuse and psychiatric outcomes. And in contingency management, we consider a 3-month follow-up period to be a really long time, which I think is sort of something we need to work on. So, while contingency management is pretty simple, here's the details of what our contingency management intervention looked like. I'm glad to talk with you individually, but if I sit up here and describe the whole thing, it would take a while. But basically the idea is that in all of our studies, we compare the contingency management condition, which is getting rewarded for showing up and being abstinent, to a control condition. And our control condition is called non-contingent reinforcement. So what that means is that you get rewarded just for showing up. So when I come in and I have a visit with Frank, if I'm randomized to that condition, I come in on Monday, Wednesday, Friday, and I just give a urine sample, and it doesn't matter what the results are. I get prizes anyway. So that's our control group. And we balance the amount of prizes you get in the control group with the amount of prizes that the folks received in the week before in the treatment group. So the idea is that we all might do better if we got prizes, right? It would be nice. And we might function better. We might even stop using drugs for a while, but that this could have a positive effect. So we're balancing that. And the other thing is that in people with co-occurring disorders, we were thinking, you know what? It's going to be really hard for them to come in Monday, Wednesday, Friday unless we offer them some incentive just for showing up. So we were worried about missing data in the control group. So those are the kind of two schedules of reinforcement for our participants. So the control group is this non-contingent group plus treatment as usual. The treatment group is treatment as usual plus contingency management. So here's our consort diagram. We had 205 people consented, 176 randomized, and the first finding of this study was you get what you pay for, which is if you reinforce people in the non-contingent group, right, for giving non-contingent rewards, they just get reinforced for showing up. Surprise, a lot of them finished the 12 weeks of treatment without dropping out. So our dropout was defined as 3 weeks of no contact with Frank or one of our other research coordinators. But if you tell people you're only getting rewards for showing up and being abstinent, fewer people want to do that. So we sort of had the opposite problem what we thought we were going to have. We wanted to use this non-contingent group to make sure that people kept coming back, but it worked a little bit too well. So the first finding in our study is that people in that contingency management group, for instance, we had this guy who was a young guy, was using, I think, methamphetamines, really depressed, maybe bipolar, and suffered from bipolar disorder, and he had to take 3 buses to get here from South Puyallup to get to the clinic. And he sort of walked in, and I think he tested negative maybe, and he got 1 prize. And it was a $1 prize, and he was kind of looked at, I think it was either you or me, and it was I was somehow, I was down there at the clinic, and he's like, what? Why would I want that? So it was not, for him it wasn't enough. And that makes sense. I wouldn't want to take 3 buses anywhere. So that's the sort of first finding in our study. Our dropout rate was about 9% less than we would see in people who have cocaine dependence. They were getting contingency management but aren't seriously mentally ill. But our completion rate was much higher than in other contingency management studies in the control group because we were rewarding people for showing up.
Trying to get on the phone weekly?
Every Monday, Wednesday, Friday, for 3 times a week for 12 weeks. That varies by every individual. If they're getting IOP, it might be 3 times a week. Intensive outpatient addiction treatment. The question was, how often are people coming in for the treatment, contingency management treatment? How often are people coming in for standard care? So it's community mental health. So typically, if you're not getting it structured addiction treatment, you're probably coming in 2 to 5 times. 2 times a month would be the low end, and I'd say 4 times a week at the high end because a lot of folks had payees, so we were right next to the payee desk. Strategically. So people would come in for protected payees, relatively frequently, at least 2 times a week. So it really depended, Chris. That was sort of we actually created a measure because it was so widely variable in our population. We had a self-report measure of their treatment utilization. So despite the fact that people we had this higher dropout rate, when we looked at and we used kind of very complex statistical techniques, which I could talk about a little bit, or at least refer you to other people who could tell you more. To account for those missing data, what we see is about 2.5 times more abstinence in the contingency management group. So even though people might not have showed up all the time and maybe a few more people dropped out, what we see is still overall we see a fairly large reduction in substance use. And this is number of percentage of stimulant negative urine samples by group. So you can see there's a pretty large effect size. We're getting like 90% abstinence in the treatment condition. So we're excited about that. That's sort of what we expected. Contingency management's been researched in 100, studies or so in other populations, and we sort of expected that. And then this is what we hoped for. So this slide shows inpatient psychiatric hospitalizations, the number of people hospitalized before and after the intervention by condition, and the days hospitalized. And this is in King County. So most of our people were hospitalized in King County. I think we had maybe 1 person that went to Western for a while, but I think on the way went to King County, had a hospitalization here. So what you can see are these pretty striking differences. The 3 months before the intervention, before the randomization, there was 1 person hospitalized in each group, and the days, so there's 1 person in each group, and the days are not that different. But when you look at the 6 months after people were hospitalized, after they were hospitalized, the 6 months after they were randomized, you see many more people in the non-contingent condition, and you see a huge difference in the number of days hospitalized. So this was something that we were pretty excited about. And if you think about what the county pays for a day of hospitalization, pays Harborview, and the cost that the cost of hospitalizing a person for a day versus this intervention that we delivered, which is about $250 per person for 3 months, you can see the sort of cost savings here. So not only did we find that, but we also found out that people reported in the contingency management group, they reported less stimulant use for 3 months after treatment relative to the controls. They reported less alcohol use during treatment, less injection drug use during treatment. We actually had a fairly high, about a quarter of people at baseline to 30% were injecting drugs at baseline. See a big change in there. We also found, even though we weren't targeting cigarette smoking, we saw a reduction in cigarette smoking, and then a reduction in psychiatric symptoms, and that was really not around psychotic symptoms, but more around mood symptoms and just overall distress. We saw a real reduction there, So the conclusion is sort of this is an effective treatment that we can add on to treatment as usual in a typical community mental health center in a relatively urban setting. 60% of these folks were homeless during the study at one point or another. These were sort of the typical downtown folks who are living downtown or and minimally housed, or if they're housed at all, that a lot of you see here at Harborview. So again, here's back to the cost. So if you don't count the staffing costs, I don't have staffing costs in here because a medical doctor could do this if you wanted, but the front desk staff could do this intervention after we train them. So the staffing costs can be very variable. So really variable. So what this cost includes the cost of the urine analyses, the tests that we do, and the prizes for folks. And we track this throughout the study. And we find it's about $255 per person for 3 months of treatment. And again, that average Medicaid payment for a day of hospitalization is about $800. Now, of course, as you know, everyone who works on the patient knows that doesn't capture the cost of actually being hospitalized, the cost we're incurring. So that's the first study. So based on that study, we thought, well, now we've targeted stimulants, and I'll talk a little bit more about this, but what about alcohol? And I'll talk some more about the context and contingency management research around alcohol and why there hasn't been very much. But this is our second study that is an R01 that I'm the PI on. And again, we're pretty much the same team, just keeping things going. So as I talked about, contingency management has really been shown in a number of studies to be effective for drug use. But that's because we can implement this intervention. We can't make people come in 5 times a week or 6 times a week. We're already pretty stretching it at 3. And so we have these urine cups that can test for other drugs, and they can detect drug use for 2 to 3 days or more for like marijuana. So we can have people come in 2 to 3 times a week. Some people, especially if they're in intensive outpatient addiction treatment where they have to come in that often anyway, that works for them. But we can't do it more often. But alcohol is different because there's really not a viable alcohol biomarker out there. So NIH funded some pretty big studies before on alcohol, contingency management for alcohol, where you come in Monday, Wednesday, Friday, and you give a breathalyzer, right? So what happens if you come in on Monday and give a breathalyzer? Well, you could have partied all Saturday night. You could have partied all Sunday night, right? And you walk in and you blow in this breathalyzer, and you're negative, and you get all kinds of prizes. So really, there's only been 2 NIH funded and I think 3 published studies on contingency management for alcohol because of this lack of a biomarker or a measure of abstinence that we can use. So that's that. So despite the fact that most people with serious mental illness, alcohol is the drug of choice, or alcohol is a drug that's really getting in their way, and that's just true for the general population too. So there's this biomarker. I remember Rick saying there's got to be a urine test for alcohol. And lo and behold, after we did some digging, and if anyone works in like the drug court populations or similar populations, or physician monitoring programs, or the other group, or provider monitoring programs, or the other group that uses this biomarker, it's called ethylglucuronide, and it's a metabolite of alcohol, and it can detect. The company says it can detect for 5 days, a little bit of drinking, but that's really not what our data supported. But it can detect about 72 hours post alcohol ingestion your use of alcohol. And you can detect it in your urine, and we can use an analyzer. We can't do it just in a drug cup, so it's not like I can just hand it to you and you go give a sample and I push a little button or whatever the cup, just dip a little stick in and it tells me the result. You have to use a urine analyzer, so it's a little bit more, it's more costly, and the urine analyzer is about $40,000, so it's not like a super unreasonable cost. It's not something my wife is going to let me buy tomorrow. But but it's reasonable. It's something that could possibly be something we could use in contingency management and other applications. So in our work, which has been fairly substantial now, in the work of other folks, we found that a cutoff of about 100 nanograms per milliliter can detect 2 standard drinks or more for about a 2 to 3 day period. Now, if you use more than that, we're going to detect we'll find that metabolite in your urine for up to 5 days. But for even little bits of drinking, we can pretty much detect that for about 2 to 3 days. So here's our, we call it R2P2. This is our urine analyzer. It's more commonly called the Indigo. And you can see, if any of you have done lab work, like this is a pretty little machine. Like it would fit on this table. I can use it. I even wear a lab coat, and I use it. And with help from one of my staff, I can actually use it. I have to text her back and forth until I finally figure it out. But it's fairly easy to use, something a clinician can use. You don't need to be a lab tech to use. None of us are lab techs. So that's good old R2P2. So before we were able to buy that with NIH money, we had to do some pilot work. So my son loves to tell me when we're pulled up to stoplight, if I can go, if it's green, I can go. If it's yellow, I need to go very slow. He's still confused about yellow. And if it's red, I have to stop. But his description fits for this figure. So in this figure, we did basically an ABA design, although it ended up being technically an ABCA design. Where we had 15 people come in at WSU who are alcohol dependent. These aren't seriously mentally ill adults. We're really trying to see in this pilot study, can we use this ETG test as the basis for a contingency management intervention? So for the first week, for the first 3 weeks here in green, people are just coming in and they're given an ETG sample twice a week, and this is the rate of abstinence in that group. So we tell them, we give them prizes for coming in. We're giving them vouchers. We're paying them, I think, actual cash. So they're coming in for the first 3 weeks, and you see about 60 to 50% of the samples are negative for ETG. Then we were worried about ETG being oversensitive, because that's the perspective out there in the world of alcohol biomarkers. So we warned them in this week. This is a really interesting phenomena. We warned them, you know what? You need to knock off your drinking if you want to get prizes in this next condition, where we're going to tell you to stop. And lo and behold, 80% of people knocked off their drinking, and they're abstinent as far as ETG could detect during that week 3. And then the red is stop. We're going to give you rewards for not using. So you can see we have rates of abstinence that are anywhere from 85 to 100% during that time. And then we go back again to green and say, go ahead, you can drink now, you'll get rewards just for showing up. So it's a demonstration that we really can use ETG, and we see an effect size, and when we did statistical analyses, we see an effect size of like an odds ratio of 5 times less drinking. So that was the basis for the current study that we have ongoing. And this primary aim of this study is really sort of about, contingency management we know works, we know it's going to probably be effective for alcohol, but it's really, can we use this biomarker in this unique population that's sort of been understudied. And so we're recruiting about 120. Our goal is to recruit 120 alcohol-dependent adults with serious mental illness, and we want to see if we are able to see changes in of course alcohol use, and then other things like smoking, medication adherence. A lot of things we didn't measure in the last study that we wish we would have. So things like smoking, medication adherence, and then some of the things we've already measured. And then really, can ETG be a clinical tool? Is this like a viable clinical tool for treatments like contingency management and other treatments? The other thing we did different in this study is that we used this thing called an induction period, which I thought was just a great methodological idea that we picked up from a contingency management researcher named Ken Silverman, who's in Baltimore. And we thought and what he basically has shown with his folks he works with who are very severely heroin dependent, is that if he just reinforces them for 4 weeks for showing up, then when they get assigned to the contingency management treatment, a lot fewer of them drop out, because they've had just 4 weeks to show up and see what it's like to get the reward. And basically, he says, only those people who show up regularly get to be in contingency management. Because if you can't show up because you get prizes, like if we can't show up to work, why would you think you could show up to work and be abstinent? So it's like, if you can't show up 3 times a week and just get prizes just for showing up for those first 4 weeks, you're probably not going to even be clinically, it's not clinically indicated for you to even be in contingency management. Does that make sense? So the idea is, in the last study, we're probably using contingency management, and it wasn't a good treatment match. Like for a lot of those people who were randomized to contingency management, it's probably just not a good match for them. Right now, they might try another kind of intervention. So So what we did is that in this study, what folks do is they come in, they consent to the data, to the procedure, or to the study. They are then in this induction period, and then you're here, Frank. That's great. And then if they show up at least once in that last week, is that what our rule is?
Yeah.
Then we have a very minimal thing for showing up. You just have to show up once in that last week of the induction period. Then you're randomized. People who don't show up, who sort of drop out, just they can't show up 3 times a week, or they can't show up at all for that when they get prizes. Those folks are not randomized. So then folks who do continue through that induction period and remain eligible are randomized to either the contingency management group, or also in this study reinforcing people for attending their intensive addiction treatment. So they also get additional gift cards, not only if they're abstinent, but if they also show up for treatment. So we're giving a little bit extra reinforcer because we're hoping to hook people back to treatment that's ongoing, so that they stick to their treatment, and that will hopefully help them maintain their abstinence in the future. So here's our progress so far. We're about 1.5 years into this 3-year study. We are almost at our recruitment goal. We're doing great, in my opinion. We have consented 51 people. Only one was not eligible. There's a lot of people drinking. We had forced 5 people into contingency management condition. This is a common thing you do in contingency management. That establishes the rewards for the non-contingent group. So that's just a methodological thing. And then about 24% of people who have finished that, who are have gone through 4 weeks in our study, the first 4 weeks, about 24% of them have not made it through that induction period. So those folks are kind of referred out to treatment and are not randomized. We have 6 people that are in that induction period. We've randomized 27. And look, compared to our other study, I mean, these are initial data, but compared to the other study, we had a 60% dropout rate. Here we're having a 30% dropout rate in contingency management. So we're really thinking we're for at least some of the people who this is just, we're getting maybe those folks who this isn't appropriate treatment for, they're not in the randomized sample, and so we're seeing a lower dropout rate. So that's our progress on that study. So now it looks like we're going to have some extra time to talk about our new research, which we're very excited about. So the research that I've become more and more involved in through collaborations with Deidre Buchwald, who's in the Department of Epidemiology as well as Medicine, and then John Roll is focused using this contingency management, particularly for alcohol, to treat addiction-related health disparities in American Indians and Alaska Natives. So we're sort of moving from one population that suffers from addiction health disparities to another population. So we have 2 funded studies in this area. The first one is a P20 center grant that is a collaboration between WSU and UW and Dr. Roll and Dr. Buchwald. So Dr. Buchwald, for those of you who don't know, is a world-renowned Native health researcher, and she does research in almost every area of health, and more recently has gotten really interested in, and we've developed this sort of program of research, at least now initially, in substance abuse. So the idea of this study, there's 3 grants. There's one on smoking cessation for college students using text messages. Then there's another one for attachment-based intervention for moms and their kids, infants, focused on trying to prevent substance abuse at a very peripheral level, at a almost primary prevention level. And then there's our study. So there's 3 projects in this grant, and our project is focused on using contingency management to treat alcohol and then opiate prescription drug use. Our partners, when we're trying to come up with these grants, we really try to work together collaboratively in a sort of, people call it community participatory research design. We really try to work collaboratively to try to to create something that's going to be positive for the community, not just a scientific study for the sake of scientific study, but something that's going to actually make an impact in the community. And the feedback we got from all of our communities was, wow, we're seeing this huge increase in prescription drug use. And it's an uptick that's later than what we've seen in Seattle. So this is it's a little bit behind what we've seen. We've sort of seen an uptick and then continuing to go sort of up and then flat. They're really seeing a huge uptick. They continue to see that. So in this study, we're targeting both alcohol and opiate abuse, and or misuse, and we're doing it in 2 rural communities where they don't have access to other kinds of treatments that other folks might, like Suboxone or Vivitrol. Those things are just not as available. So the idea, and they also don't have they also don't have trained therapists. So, for instance, one of the communities we're partnering with in Montana, they actually don't have they have a tribe of I think it's 15,000 folks, tribal members. They don't have one certified addiction treatment counselor when we proposed this study. So the idea again is contingency management. You don't need to be a certified addiction therapist to be able to do it. So in this study, we're going to do things a little bit differently. People are going to be randomized to alcohol, contingency management for alcohol only, contingency management for prescriptions or just opiates in general only, and then contingency management for both. So some people will have to quit using both at the same time, which is going to be interesting to see how that goes. And then we'll have a non-contingent control group. And our tribal partners, again, said 3 months is not long enough. We want to follow people for at least 6 months. We would like to follow them for 2 years. And there's only certain things we could do within a grant, but we're going to have a longer follow-up period, which I'm excited about in that grant. So that's one project. The other project that was just funded on September 1st of this year, so just was recently funded, and Dr. Buchwald and I are co-PIs on this one, is to determine the efficacy of a culturally tailored contingency management intervention for alcohol abstinence in 400 American Indians and Alaska Natives and 3 sites throughout the West. So we're pretty sure, we don't know for sure, but that this is going to be the largest randomized controlled trial of a substance abuse intervention in Native communities ever. You might not know, but there's only 4 published randomized controlled trials of substance abuse treatments in American Indians or Alaska Natives. So it's a huge health disparity that's really been underfunded and understudied. So in this study, we're going to do one thing a little bit different. We're going to have some pretty intense focus groups and work with communities around what we could change about contingency management. We can't really change a whole lot, right? We're going to change the prizes. We're going to change maybe who delivers it, but we're going to try to work with communities to make it as tailored as we possibly can. First, and then we'll use this induction period strategy, which we found to be so successful, and then randomize folks to one of 2 conditions, and then we'll have a 3-month follow-up in this study. So that is a quick summary of all the research we have going on with contingency management in these 2 communities or populations. And this is our team. I mean, I just say a huge thanks to Rick Reese, who's been just a fantastic mentor and really supported me as a junior faculty member sort of to become an independent researcher. So he's out fishing now. He didn't come. His support's kind of dwindling a little bit. He's out fishing. I'm kidding. So he is fishing, though. And then, of course, our colleagues at WSU, and I can't say enough about, the last study we did with Rick in people who have substance abuse disorder and serious mental illness. Because of Frank and Jessica, we finished that study, recruitment for that study a year early. So we have a great team, and community psychiatric clinic is a big part of it. They really have been great to work with. And then we have our team here for focused on American Indians, which of course includes Dr. Buchwald as well as other folks who have experience in this area in our department, like Dennis Donovan, and then a bunch of our colleagues at WSU. So that's all I have to say. Questions? Mm-hmm. John?
My understanding is that economics theory, like somebody will take $2 payment for a $10 payment, or $10 for payment. I just wondered if you could comment on why you think that's the case. Do you have any intuitions on what's going on with that? Is it because there's something intangible about the process?
Yeah, that's a great question. So the question, just to repeat it for other folks, was: is there some kind of process? Why do people choose these reinforcers over drug use? And is there some sort of algorithm or neuropsychiatric basis for that? Is that what you mean, John?
Yeah, I mean, if you do, like you could have a discount.
Yeah. 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 Yeah.
So in a way that isn't irrational.
Yeah.
So you're somehow jumping on the fact that human drive crash.
Yes. Yeah. So I think Yeah. So I guess I could be paid more to work at Las Vegas, although I don't do that kind of I don't do that depth of research. There's the delayed discounting phenomenon is something that's like swept across the whole drug abuse field, but in particular contingency management. Warren Bickel, who's doing all kinds of stuff on delayed discounting and finding that the more people struggle with the delayed discounting, the more intensive their reinforcers need to be, the higher the magnitude, and the more frequent. So we definitely know that. If you think about like physician monitoring programs, right, where you have these folks who cognitively are able to think, wow, I have a lot to lose. If I mess up just one time, so these are folks who have a substance abuse problem, or physicians or nurses, I think, have a similar program, and so they're drug tested randomly, et cetera, and they have a lot to lose if they're positive. And so the idea there is that they can think about those long-term contingencies possibly more than other folks. more than our folks who are serious mental illness and drug addiction. So I think the field of behavioral economics, and I can't exactly answer your question, I guess is what I would say, because I just don't know that area well enough. But what's happened is at a public health level, these behavioral economic theories have sort of been developed separately, where they sort of figure out, a lot of you are probably part of this. If you do a smoking cessation program, you might get $100 back from your insurance. Or there's some really good research that has been published in the New England Journal on this. They'll just pay people at larger amounts but less frequently to engage in health behaviors. And so I think that, at least my understanding is at this point, that people who have can have more impulse control, can wait longer. That those are the folks that that can really pick those 2 marshmallows 5 minutes from now over the 1, do better with less frequent reinforcement, but in lower magnitude. But for people who really struggle with that concept, they want the 1 marshmallow, right? That they need the more intensive intervention. And in particular, Nancy Petrie did a study where if they came in and they tested positive for cocaine use, she gave them twice the magnitude of reinforcement as the people who didn't test positive, and found she found a much larger reduction in substance abuse than in her previous studies.
So like methadone versus
Yeah. Uh-huh.
they were offering 15 vanilla cocaine for $10. And so they just said, I want $10 cocaine, I get $2 reward.
And you can't spend cocaine. And you can't spend cocaine.
But my understanding is that, like, when they do this with the animal models as well, too, that there's no theoretical explanation.
Yeah.
That they can't, all the people who have equations explain decision making, they cannot explain contingency management, it defies all the cool.
Yeah, so John there's been a discussion from folks at the UWMC about kind of why people would choose this $10 of cocaine over less money. And John Neumeier was saying that it seems to be that this, in animal models, this really hasn't been explained. Yeah, I mean, as a behavioral psychologist, I'm not necessarily a strict behavioral psychologist. I would just say none of that matters. You just give people rewards and they do what you want them to do. I'm just kidding, John. I'm kidding. I think he was first.
One of the things that might be interesting with cell phones being everywhere and smartphones being around, that would be a fantastic way to provide a certain amount of reinforcement. Either phone time for folks that don't have enough money to buy phones, or payoff if somebody does something, like they show up to work, they push in these buttons, or they run it by a scanner at work, and all of a sudden they get $10 on their chip.
So the comment was this would be a great application for like mobile technology, and so my response to you is to look immediately to your right and introduce yourself to the person sitting next to you who is very interested in that. Roger Villadaga, who's our postdoc that works with Rick and I. You're right on. I mean, there's actually, I was talking with Paul before. There's actually I call it in our lab the Lindsay Lohan bracelet. There's a transdermal alcohol monitor that you have patients I'm sure who wear these. And it's used in the court system. But the idea is, could you hook that up with a smartphone? And could you deliver reinforcement? There's actually somebody who's doing research with that monitor over in Brown. And could you have a complete contingency management closed loop without a need for a human being or a clinician? And I think that's pretty sort of exciting, or at least the clinician would facilitate that. So definitely Roger has some interest in that, and I think it's a great idea. There's a few.
This whole discussion we had, I think this is why conventional economists talk about, but mostly ignore what they call externality, which is the hidden cost and financial cost.
Mm-hmm.
So if you talk about the hidden cost and everything else involved in using automobiles, you think about the automobile, but same thing with this cost. There's a lot of cost and benefits.
Yeah. So the comment was that there's a lot of costs that are not accounted for economically in sort of comparing the contrast of $2 worth of money versus $10 worth of cocaine. I think that's I definitely agree that, people are rational. They know that cocaine's not good for them. And maybe not in the moment, but they know, and so that might definitely play a role. All those kinds of contextual factors might definitely play a role in their decision.
I'm just curious about as far as how often did when you follow people afterwards, how long did you follow them for? Because I'm curious as to whether the reinforcement continued to work. Like once that reinforcement is taken away, how long did that actually last?
So that is the major critique of contingency management, which is when you take away the reinforcers, it doesn't work, which is similar to when you stop using most drugs. I mean, when you stop using more medications, they tend to quit working too. But there have been studies that have shown up to a year of effect, and they've been mostly studies that have shown a comparable effect to cognitive behavioral therapy, evidence-based cognitive behavioral therapy for addiction. So there's been up to a year. So we followed people for 3 months, which again, remembering this is a behavioral psychology tradition, so 3 months. The idea of a follow-up period is sort of unique, and I think is being extended as we do comparative effectiveness research. The idea is, I'll give you a personal example. Like, I use contingency management myself. So I was overweight. My dad had just had 2 strokes and a heart attack. I've been a runner before. I decided I needed to run. And so I made a deal with my wife, who some of you might know, to basically that I could earn $1 every day for a year, and for running 20 minutes every day consecutively. But if I made it to 364 and I fell and I broke my leg, she got all the money. She could buy whatever she wanted. So I fell down a cliff a hill about this tall, about as tall as the podium, and in the middle of my run, and I had to run the next day, and she ran with me, and it was like the longest 20 minutes of my life. But I got that $365. But by the time I got that $365, I had bought this running watch. I had signed up for 2 marathons. I had done all. So that's the theory underlying this is sort of that people will develop their own natural reinforcers when you're able to help them move away from that thing that's been the only reinforcing thing in their life. Again, it's a complex process, but I think that's one theory. There's also an intervention called community reinforcement, which is it takes more of a contextual approach to sort of how can you develop your own natural reinforcers to do these things, or even more structured. And there's been a long support for that, especially in substance abuse research and with adolescents.
Additionally, this is one of the reasons why we added the IOP, the reinforcement for participation in the IOP treatment, is to also link clients up to once you take away the reinforcement for visiting us Monday, Wednesday, and Friday, they'll actually have some place to be as well as can kind of continue their supply. So,
I think, Dick, did you have a question?
What does risk come into this? I mean, if you're out on the streets and, you get somebody that'll pay you to come in, and so you give up $10 for the cocaine, you get $2, and you're not very risk averse, then maybe you'll go for $10 worth of cocaine. But if you're moderately risk averse, then you'll get $2.
Yeah.
So this risk is right in the middle of all that.
Yeah, and I think that's why the running thing, the $1 a day for me worked. Because that's sort of the way I think. I'm a low risk taking person. Like, I don't go to casinos, and that's where. And again, I'm a little bit behind on this research because I've been trying to write grants myself and keep sure I have a job. But I think that is about sort of they've done that is the big. This is what this delayed discounting thing is sort of about. It's sort of like am I going to accept this one marshmallow now or wait longer? Can I? So that's more impulse control. And what we know about the folks who are especially use substances is that they're not as risk averse in general, and that maybe it's people who are, again, it's sort of this treatment matching thing, and I think there's a lot of work that's being done that I'm not necessarily aware of, and others in the room probably know more about than I do, but I think that's definitely a big piece of this, is sort of, like, maybe that's why we see this dropout rate. For some people, this is so, they're so risky, or they're so willing to engage in that, that's not as effective. This isn't as effective for them. The other side of the things is it's a big risk to stop using drugs. Like it's a risk you're taking to try something else. So that's sort of another way to think about it too. Yeah.
Thinking about operationalizing this, 5 years down the line, and what might kill it. It's thinking about strategies that are going to affect the Rush Limbaughs, the Fox network people that are going to make fun of this.
I got that
trying to figure out a way to inoculate them. Like it might be, this is the American way, you get paid for blah, blah, blah. This is, get the Koch brothers to fund this kind of research. And
I like that.
And that way you may eventually be able to get the point that it will get funded and not killed, because this has a lot of risk to get killed with the kind of bizarre stuff that's out there now.
So I'm sorry, I haven't been repeating all the questions. So the question was sort of like the right wing. It was a political question. That the right-wing conservatives in our country will kill an idea like this. So I have to disclose that I am from Eastern Washington, and I'm a pretty libertarian kind of guy in some ways, and in other ways not. And I think that that to me this is people get paid for doing what they do. I mean, this is sort of like we're rewarding people for doing the right, making good choices, and some people may be uncomfortable with that. The feedback actually the feedback that we've actually gotten is the other way. Is that recovery-oriented people don't like this. People should do this on their own. Folks who are really invested in AA, we've gotten a lot of feedback from people until they've been exposed to what we're doing and sort of see some successes in their clients or their consumers. That this is not part of the recovery model. People should have internal motivators to do this. People should want to do this. They need to work their 12 steps. I don't see these things as I don't see them. I'm more dialectical. I see them together. Like I don't see the difference. But those we've gotten feedback from both sides of that spectrum.
So I hate to cut everything off, but we do have to finish up here. So thank you, Dr. Dole.
Thank you, everybody.